Okay, well, I'm going to go ahead and get started. I have to say this is one of the weirdest things I've ever done, that I'm talking to a group of family practitioners, but you all aren't sitting out there. But I am excited to be here, and I'm excited to give you talk on a subject that's pretty near and dear to my heart, which is menopause. I originally started with the idea of calling it menopause, what you need to know. And I quickly realized that what you need to know is that a lot has changed on how we look at the use of hormones in perimenopausal and postmenopausal women. So I changed it to update on hormone replacement in menopause. So I'm Dr. Becky Lynn. I'm a gynecologist. I'm the director of the Evora Center for Menopause and Sexual Health in St. Louis. I'm also an adjunct associate professor of OBGYN at St. Louis University. So thank you for listening to my talk. So let's get started. These are my disclosures. As you can see, I really love talking. So I love teaching, I love talking. So if anybody asks me if I'll speak, I'm always happy to do so. So the objectives of this talk are to kind of review what is menopause. I know you all know what it is, but just the basics. We'll talk a little bit about the history of hormone replacement therapy, and then where are we now in terms of hormone replacement therapy. And as luck would have it, a practice-changing article came out 2 days ago in JAMA on hormone replacement therapy and the risk of breast cancer. So we'll talk about that. We'll also talk a little bit about sexuality and hormone replacement therapy. Besides menopause, I also specialize in sexual problems in women like low libido, painful sex, and they really do go together, since menopause and those issues in particular often overlap. So we'll talk a little bit about the role of hormone replacement therapy in sexuality. And I also want to point out that hormones are not the answer to everything. Many of the menopausal symptoms that women have can be treated without hormones or treated with different medications. But today's talk, we're really going to focus on the hormone side of it. So the take-home message that I think is really important is hormone therapy can have tremendous benefit in the right patient at the right time. And I'll expand on that a little more. But in my opinion, we should throw away the idea that all hormones are bad, because they're not. There really are some benefits in the right patient at the right time. But there is nothing without risk. So when you have these discussions with your patients, when I do, I typically go through the risks, the benefits, and the side effects. Because if anybody tells you this drug has no risks, they're lying. So what is menopause? Menopause is 12 months of amenorrhea after the final menstrual period in a woman over the age of 45 in the absence of other causes, biologic or physiologic. And at the time of menopause, this is when your ovaries have run out of follicles, basically. It reflects complete or almost complete ovarian follicular depletion and the absence of ovarian estrogen secretion. So basically, your estrogen from your ovaries goes away. Your ovaries are no longer producing estrogen. You still have a little bit of estrogen around, and you get that estrogen from your fat cells. So there are factors that influence the timing of menopause. The average age is 51. Your genetics play a role. So if your mother was older, you have you're more likely to go through menopause older. At an older age. It depends on your ethnicity. So Hispanic women go through earlier than Caucasian women in general, who go through earlier than Japanese women. Smokers go through menopause earlier. Women who've never had babies or who are nulliparous. And if you had a shorter cycle length during adolescence, that's also associated with an earlier menopause. Some of the long-term issues that I know you know all about are bone loss, cardiovascular disease, and dementia. When you lose your hormones, there are a lot of changes in your long-term health risks. So what are some of the classic symptoms of menopause? So we all know hot flashes and night sweats are very common symptoms, but I really want to stress to you that there are other symptoms that happen around the time of menopause that are truly due to that loss of estrogen. So hot flashes, yes, sleep disturbances. So sleep disturbances related to night flashes can happen, but sleep in general can be disrupted even without night sweats. Menopausal women, especially newly menopausal women, will often complain of short-term memory loss, which can be really scary to them. So they can remember their phone number from when they were in 3rd grade, but they can't remember what happened yesterday, and it can be very frightening. Menopausal women tend to gain weight. They tend to gain weight around their middle, so they become that apple shape, which increases their risk for cardiometabolic disease. And the loss of estrogen increases insulin resistance, which works against them as far as weight gain as well. They might develop joint pains, their skin becomes drier, and anxiety and depression are really common around the time of menopause. If you think about it, this is a time in a woman's life where she might have financial stressors, she might have aging parents that she's taking care of, she might have teenage children, or maybe those teenage children have left the house, so there's a little bit of empty nest syndrome going on, and for some women, a loss of identity. So menopause is a very tumultuous time. It's almost like a second puberty, and who wants to go through puberty twice, right? No thanks. Some of the other clinical symptoms that are very important are vaginal dryness and painful sex or dyspareunia. Low libido can happen, urinary symptoms, urinary leakage, stress incontinence, urge incontinence, and like I mentioned already, depression and anxiety. So I'm going to turn now to the history of hormone replacement therapy, which has, even over the short time that I've been practicing, has just been a roller coaster ride. And it's how I counsel patients about hormones has changed many times over the years. So in 1942, hormone replacement therapy was first approved for use in the United States. And in 1966, there was a book that was published called Feminine Forever, which was pretty much touting hormones as a cure for the disease called menopause. Well, it was touting estrogens. But we found out at that time that if you give women unopposed estrogen or estrogen without a progesterone, that it increases the risk for uterine cancer. So in the mid-1970s, it was recommended that for women who have a uterus that you add a progesterone. In 1988, the FDA approved hormone replacement therapy for the prevention of osteoporosis. And in the 1990s, there were several observational studies that showed a decrease in coronary artery disease, mortality, and the risk of Alzheimer's disease in women on hormones. So at that time, in the 1990s, the FDA decided that we really need a long-term, prospective, placebo-controlled trial to get some more definitive answers on the benefits of hormone replacement therapy, and especially in its relation to prevention of cardiovascular disease. So these are just some old ads. One of my partners found these. I have no idea where he found them, but they just blow my mind how far we've come since these days. They're a little sexist, not a little, a lot, but we've really come a long way. So in the 1990s, you can see that there were many observational studies that showed that estrogen or estrogen and progesterone replacement decreased the risk of cardiovascular disease. And I can even remember before I went to medical school in the 1990s, I was working in a lab, and I remember them talking about how, estrogen affects the risk of heart attack. And I was like skeptical. I don't know why I was skeptical, because I wasn't even a pre-med at that point. But yeah, so in the 90s, that's what we were very excited about. Also, in 1998, there was the HERS trial, the Heart and Estrogen Progestin Replacement Studies. And this one was a randomized, double-blind, placebo-controlled trial. And it was looking at conjugated equine estrogens, that's what CEE stands for, plus medroxyprogesterone. Mind you, this is the formulation that was used in the WHI, versus placebo on the risk of recurrent CHD events over a little over 4 years. And they looked at over almost 3,000 postmenopausal women, average age of 67, looking at heart disease. And what they found, to their surprise, that unlike the observational studies, HRT in postmenopausal women with established heart disease did not see a decrease in the overall risk of MI and heart disease and death related to heart disease. And in fact, HRT in the form of conjugated equine estrogens and MPA, or medroxyprogesterone acetate, significantly increased the risk of events in the first year, followed by a reduction in years 4 and 5. And you can see this here, right here, that increased risk, especially in year 1. And remember, this was a pretty old, no offense to anybody's in this age group, an older group of women, average age 67, when you compare it to women who are newly menopausal in their early 50s, and their underlying risks of heart disease are very different. But still, it was kind of a surprise. So along comes the Women's Health Initiative, which I know we've all heard of ad nauseum, because this changed the fate of hormone replacement therapy forever. So what was the Women's Health Initiative? And I apologize if you've heard about this over and over again, maybe not. This was a randomized multi-center trial of either ERT, or estrogen replacement therapy, or estrogen plus progestin therapy versus placebo. So what it was looking to find, it wasn't looking to assess whether hormones help with hot flashes. That was not the main outcome. The purpose was to assess the long-term risk-benefit ratio of estrogen replacement therapy and hormone replacement therapy in disease prevention, primarily cardiovascular disease. That was the primary outcome, or the primary endpoint that they were looking at. And they were also looking at the incidence of breast cancer. And in the WHI, they enrolled 27,000 women between the ages of 50 and 79 with an average age of 63. So once again, that's very different from your 51-year-old who's having terrible hot flashes and can't sleep. And it was scheduled to be over in 2005. This is just the participants' baseline characteristics. You can see that the average age is really what I would like to point out here. Okay, so what did they find in the WHI? So they found that women on estrogen and progestin together had an increased risk of coronary heart disease, stroke, pulmonary embolism, and breast cancer, and a decreased risk for hip fracture and colon cancer. And at this point, they stopped the trial early because they believed that there was clear harm in what they had found. In the estrogen alone group, so women who had had a hysterectomy, they found an increased risk of stroke and a decreased risk of hip fracture, but no change in breast cancer, no change in pulmonary embolus, no change in coronary heart disease, but they did stop the whole thing early, both groups. So why was there a big discrepancy between the observational trials, which made you want to put all your patients on estrogen, and the randomized controlled trials, which scared the bejesus out of everybody? So one of the main differences is that the observational data looked at women who initiated hormone replacement therapy at a younger age, whereas the WHI, the average age was 63, and in the HERS trial, the average age was 67. So timing is everything, and we'll talk about that more. So in 2003, when that happened, I remember I was a resident. It was all over the media. Hormones are bad, hormones are bad, hormones are terrible, terrible, terrible. Everybody stop them cold turkey. And if you stop hormones cold turkey, your hot flashes will come back with a vengeance. So it was a really tough time, and it got a lot of media play, But after the trial ended, they continued to collect data on women. And over the last 20 years, more studies have come out looking at the WHI data and continuing to collect it. And they found out that how they read the results of the study in the beginning were really, some of it was kind of wrong or misleading, more so misleading, and I'll explain. And the reason I have a zombie up here, and I fully think this whole bad reputation of hormones is a zombie idea. It just refuses to die no matter what you do. That term was coined by an economist, but it so applies here. And there are so many women and practitioners who really believe that hormones are just plain bad. But in those last 20 years, we've gathered more data, and we've stratified the data by age. And when you stratify the WHI data by age, what you find is completely different than when you look at it all together. So when you stratify by age, this was published in 2006, it was found that in younger women, women in the 50 to 59-year-old age group, on CEE had a more protective effect than a harmful effect, especially when it comes to cardiovascular disease. And so basically, we sort of missed a generation because, and I'll talk about all the benefits of starting hormones in your early 50s in that 50 to 59-year-old age group, but it's been almost 20 years. And so I feel like we did miss a generation of women who could have had benefit from using hormones. Let me just look at one slide here. Let me go back here to cardiovascular disease for a second. When you look at women between the ages of 50 and 59 on estrogen, or estrogen and progesterone together, starting hormones in that age group had a protective effect against cardiovascular disease, which is the #1 killer of women. I know you all know that. And so all those women that we skipped over that missed out. And according to this study, there was a public health model that showed that women who had a hysterectomy in the USA, who did not receive estrogen therapy, would be expected over a 10-year period to have an excess of premature death. So that's a lot. So what do we tell our patients? How do we counsel our patients? So in 2017, the North American Menopause Society came out with their position statement on hormones, and it's an excellent paper if you have time to read it. And over the last 20 years since the WHI, as more data has come out, the North American Menopause Society, or NAMS, has I'm just checking the time here, has come out with statements as we get more information, and they're great reviews. So like I said, when it comes to cardiovascular disease, it's the leading cause of death in women. Even though most women are scared half to death of breast cancer, we forget about heart disease. And there is consistent data, this is from Rogerio Lobo's paper, consistent data that HRT prevents coronary disease in women younger than the age of 60. And that's level 1 evidence, so there's no doubt. So how does this, what's the theory behind that? How does it work? So the thought is that if you start hormones early, before you've developed any atherosclerosis, that hormones can prevent atherosclerosis from forming. But if you start them older, when you're older, greater than 60, where you already have established atherosclerosis, giving somebody hormones can cause that plaque, it disrupts the plaque, and then it can break off the wall of the blood vessel, travel to the heart or the brain, cause a heart attack or a stroke. So that's the thought on it. In older women, because of that HERS trial, there is concern that if you start hormone therapy later, that you might have additional cardiovascular events within the first 1 to 2 years of use. And when you compare estrogen alone to estrogen plus progestin, the benefits of hormones on the cardiovascular system were higher in the estrogen alone group. What about stroke? So in that 50 to 59-year-old group, no increased risk of stroke. That's huge. I think that's huge. So if you break it down by age groups, as far as stroke, no increased risk for stroke. What about DVT? So all ages did show an increased risk of DVT. It was, if it was going to happen, although the risk was very small, it was more likely to happen in the first 1 to 2 years. But, and I think this is worth repeating, this does not happen with vaginal hormones. So vaginal hormones are such a low dose of hormone replacement therapy because they're really used locally. They do not increase the risk of breast cancer, blood clot, heart attack, stroke, any of those in any age group. And that's really important because vaginal hormones can work wonders for postmenopausal women and perimenopausal women, but sometimes women are afraid of vaginal hormones when the risks are so incredibly small. There was this French systematic review and meta-analysis that looked at oral estrogen versus transdermal estrogen, and they found that there was an increased risk for VTE in the oral estrogen users, but not in transdermal. So if you're concerned that somebody might be at higher risk for a VTE, you might want to choose the transdermal estrogen. What about breast cancer? This is every woman's biggest fear. I understand why. So, you know, it's very complicated. And really the risk of breast cancer likely depends on the type of hormone therapy, the dose, the duration of use, the regimen, route, prior exposure, and then the individual characteristics of the woman. So in the WHI, up until Monday or whenever the paper came out, we used to say that in the WHI in women on estrogen alone, there was a decreased risk for breast cancer that was not statistically significant. But now, as of this new paper in JAMA, and I'll show you the reference, over time, collecting more data, now the WHI results suggest a statistically significant reduced risk of breast cancer in women on estrogen alone. Now that's a game changer, right? Like we're all afraid of estrogen. These are not in women who already had breast cancer. These are in women without breast cancer. The data didn't change for the estrogen progestin arm, the CEE-MPA. It did show an absolute risk of breast cancer that increased, but it was rare. So here's this paper, and basically they have, like, if you don't want to read the whole thing, they have this nice little on their abstract, the meaning of it all. And there's also a really good editorial in JAMA in the same I don't know, edition, so you can read that too. I love the editorials because you always get like a different, instead of just reading the data, you get sort of a take on the whole thing. But basically the authors wrote that the meaning of this paper was that among postmenopausal women, prior randomized use of conjugated equine estrogens in women with prior hysterectomy was significantly associated with a lower risk of breast cancer incidence and mortality. I didn't mention that. Whereas prior randomized use of CEE plus MPA in women with an intact uterus was significantly associated with a higher risk of breast cancer incidence and no significant difference in breast cancer mortality. Game changer. So basically, the other thing that came out of these follow-up studies, and we knew this before this week also, was that age stratification didn't make a difference when it comes to breast cancer risk like it does with stroke and with cardiovascular disease. So this is estrogen plus progestin group. There's still an increased risk of breast cancer, even when you stratify it by age, 50 to 59, 60 to 69, 70 to 79. And the same thing here, pretty much, in the estrogen alone arm, that there's a decreased risk of breast cancer, and it doesn't seem to vary by age. What about Duovy? Oh, sorry, I wasn't supposed to have the trade name in here, so I apologize to the CME police, sorry. Anyway, what that is, it's conjugated equine estrogens plus basidoxifene. And basidoxifene is a SERM, a selective estrogen receptor modulator. So it's in the same group as raloxifene and tamoxifen. And this one was sort of an answer to the idea that, well, if estrogen and progestin together increases the risk of breast cancer, but estrogen alone doesn't, is it the progesterone that's increasing the risk? So this drug was the answer to that, because basidoxifene is a blocker in the breast, but it still protects the lining of the uterus. So In trials up to 2 years duration, breast tenderness, breast density, and breast cancers were not increased with conjugated equine estrogen plus beta-doxaphene compared with placebo. So is medroxyprogesterone acetate really that bad? Well, I'll tell you, I don't choose it in my postmenopausal women when I'm choosing hormone therapy. I really don't. I tend to choose micronized progesterone almost always. And the reason is that some studies suggest that micronized progesterone may have less effect on breast cancer risk, whereas more potent progestins like medroxyprogesterone or norethindrone or levonorgestrel may have a more adverse effect. So just so you know, micronized progesterone is prometrium. I may not be allowed to say that, but it's important for you to know which ones are micronized, and then it's also found in Bijuva, which I'll talk about in a little bit. So you can see here, this was a study that looked at the type of progesterone. These right here are synthetic progesterones. Here's the micronized progesterone, and the relative risk was 1. So really no change with a micronized progesterone in the risk of breast cancer. So I almost always choose a micronized progesterone. What about the high-risk patients, somebody with BRCA or high risk for development of breast cancer? So there's some evidence, limited observational data, that suggests that hormone therapy use does not increase the risk of breast cancer in a woman with a family history of breast cancer, or in women who are positive for the BRCA 1 or 2 gene mutation. And this is really important because, you know, now that we are testing for BRCA and some of the other ones, we have a population of women who undergo a hysterectomy, oophorectomy once they're done with their childbearing. So let's say they're 35. So if you don't replace their hormones, that's 15 years of bone loss. You know, they don't get the benefit of estrogen on the decrease in the risk of cardiovascular disease, and not to mention, you take out their ovaries, you destroy their libido as well. So I think this is and of course you have to have an informed discussion with your patient as always. They don't have to use hormones, but I feel like when we take people's ovaries out at such a young age, there are much higher risks to doing so than someone who went through menopause naturally. So, you know, we talked about the formulation of hormones that were used in the WHI, that CEE-MPA. After that trial, I think many practitioners went to using an estradiol patch with a micronized progesterone, which you have 2 separate prescriptions, 2 separate ways to do it. But recently, there is now a combination pill of estradiol and micronized progesterone. So it's just 1 pill, so not 2 copays. And it's less confusing for patients because the patches you change twice a week. So this pill is estradiol, 1 milligram of estradiol with 100 milligrams of micronized progesterone. And in these studies that looking at this pill specific, there was no change in clotting factors, no weight gain, and no change in lipid profile parameters. What about colon cancer? So in the WHI, CEE-MPA reduced colorectal cancer by 38% during treatment. This wasn't seen with estrogen alone, but we still don't prescribe it to decrease your risk of colon cancer. What about cognition? Let me just move this little thing over here. So WHI showed a small or infrequent increase in the risk for dementia with an extra 23 cases per 10,000 person years. But there might be positive cognitive benefits when you start it in a younger woman, especially after an early surgical menopause. Hormone therapy in the early natural postmenopause period seems to have neutral effects on current cognition. Anecdotally, I'm not sure that I believe that, but that's what the data shows. And early initiation of hormones does lower the risk of Alzheimer's, where later initiation is associated with an increased risk, and also an increased risk, like I mentioned, of dementia. What about mortality? Another big one. The WHI showed that in women on hormone replacement therapy, there was a 30% reduction in overall mortality. And a Cochrane database analysis showed the same thing. So how long should you keep a woman on her hormone replacement? We used to say, according to American College of OBGYN and the North American Menopause Society recommendations, that we stopped hormones at 65. That is not the recommendation anymore. And I still have patients refer to me who say, you know, my provider said I need to stop hormones at 65, but now I'm going to have really bad hot flushes. What do I need to do? So the new recommendations are a woman should continue her postmenopausal hormone regimen as long as she wants the benefits, after an informed discussion of the risks and benefits that you have with your provider. But it doesn't have to be discontinued at age 65. And what I usually do is every year when I see somebody back, we talk about the risks and benefits, decide if she wants to stay on or come off. And I usually explain that a woman's underlying risk of stroke, heart attack, and breast cancer, those slowly go up as you age. So when you look at the risks and benefits, like on a scale, maybe when you're 55, it's worth those small risks. But maybe when you're 67, it's not worth those risks to be on hormones. So it's really up to the woman herself. So what are the FDA-approved indications for hormone therapy? Vasomotor symptoms, hot flashes, night sweats, prevention of bone loss, somebody who has a premature ovarian failure, or premature hypoestrogenism due to chemotherapy or something like that. And also for genitourinary symptoms, don't forget about those. Contraindications, history of breast cancer, heart disease, previous DVT, active liver disease, strokes, you know all that. I want to just say one thing about this whole bioidentical hormone trend and clarify what bioidenticals truly are. So after the WHI, women were scared half to death of hormones, and so outgrew this whole bioidentical compounded salivary testing thing. And what bioidentical truly means is that the hormone that you're taking is the same chemical structure as your own ovaries make. So anything that has estradiol, that's a bioidentical. So an estradiol patch prescription, estradiol vaginal insert prescription, those are all truly bioidenticals. But compounded bioidenticals should be avoided. That's level 1 evidence. The North American Menopause Society doesn't believe in it. The ACOG doesn't believe in it because they're not regulated. And they're not any safer. They're not any better. And so they don't recommend it. We know there's issues with compounding pharmacies. The FDA has done studies where they look at different batches within the same compounding pharmacy or different batches amongst different compounding pharmacies, and you can get a different amount of medicine in each one. And salivary testing depends on what you ate. So that's my personal bias. I don't buy into it. I tend to follow the national organization's recommendations because I know they look at the scientific evidence. So just to kind of sum up the systemic HRT, I hope I'm not going too long. Hormone therapy is the most effective treatment for vasomotor symptoms. In the younger age group, benefits are most likely to outweigh the risks. I want to talk a little bit about testosterone since I do specialize in sexual problems in women. And I want to bring your attention to this paper that came out in the summer of last year, because there is a lot of data showing that testosterone in postmenopausal women improves sex drive. And low sex drive is a common problem that causes distress. If you have low drive and you really don't care you have low drive, it's not a problem. But there are many women out there where it's really affecting their relationship. And if you take care of enough women, someone's going to say, hey, doc, I have low libido. It's really causing a problem with my partner, and what should I do about it? And the answer is not drink a glass of wine. It's way more complex than that, way more complex. But in that age group, you can consider using testosterone. You don't want to just say, oh, take some testosterone. You need to address the relationship. You need to address other coexisting chronic conditions, depression, anxiety, what were they taught by their family, any history of sexual trauma. So my point is not to say everybody with low drive just needs more testosterone, because that is not the case. But in some women, using testosterone may help improve their sex drive. And testosterone is not FDA approved for women. It's FDA approved for men, but not for women as of yet. And there's a lot of data that shows that it works. It seems to improve all aspects of sexual functioning in postmenopausal women. It's recommended, I always check their lipids and LFTs before starting it, because really a woman's natural testosterone starts to decrease in her late 20s, early 30s. I also want to touch on genitourinary syndrome of menopause, another thing that I think gets not asked about that's so important. When women go through the menopause and lose their natural estrogen, the vagina changes and can cause painful sex. And women don't always know that this is due to menopause. They don't lubricate and sex becomes painful and they think there's something horribly wrong with them. Or their partner might say, do you not love me anymore? Why aren't you lubricated? Or are you cheating on me? And the woman feels terrible because she may not know it's related to menopause, because these changes, they get worse over time and they tend to really show up about 5 years after your ovaries stop making estrogen. So what happens to the vagina premenopausally, the vaginal tissue is thick and it's moist and it's stretchy, and that works well for intercourse and also having a baby. And when you go through menopause and you lose that estrogen, the tissue becomes thin and dry and it doesn't stretch and it doesn't lubricate, and that's very bad for pleasurable intercourse. But the good news is you can easily treat this with vaginal estrogen or vaginal progesterone. And like I mentioned, it's minimally absorbed and not associated with increased risk for blood clot, heart attack, stroke, or breast cancer. So if your patient is having painful sex in the postmenopause and you think it's due to vaginal atrophy, please give her the hormone that she's missing that treats it wonderfully without increasing her risks. Lubricants and moisturizers are great for friction. They do not restore elasticity to the vagina. So when a woman tries to have something in the vagina, it doesn't stretch and that's painful. So coconut oil, Crisco, all of those are great, but they really do not restore elasticity. They don't bring collagen to the vagina. When you give estrogen back, it brings blood flow to the vagina, which makes sex more pleasurable. It increases the chance you're going to have an orgasm, and all of this is just as important to women as it is to men. What about women with breast cancer? This comes up all the time, right? Like if you have a woman with breast cancer, they get thrown into menopause. What is the sort of standard take on using vaginal hormones in women with breast cancer? And the various organizations have combed through the data and come up with their recommendations. So these are the recommendations from the American College of OBGYN. And they say you can use vaginal hormones if lubes and moisturizers are not working after a thorough discussion of the risk and benefits, and that data do not show an increased risk of cancer recurrence among women currently undergoing treatment for breast cancer or those with a history of breast cancer who use vaginal hormones. That's huge. ASCO, which is the American Society for Clinical Oncology, basically says just about the same thing. For those who do not respond to lubricants and moisturizers, low dose vaginal estrogens can be used. So they don't mean systemic hormones, they mean low dose vaginal hormones after a thorough discussion of risks and benefits. They also talk about ospemifene, which is a SERM in the same group as raloxifene, tamoxifen. That is a blocker in the breast, but it's a estrogen agonist in the vagina. And they also talk about vaginal DHEA, which is progesterone, and that there is one study looking at women who are on aromatase inhibitors and giving them intravaginal DHEA, and that did not increase their serum levels of estradiol. So you can consider vaginal DHEA, same thing as it's also called progesterone, and that's not the trade name. You can also use that. It's a good one. And here's what the North American Menopause Society says. Basically the same thing. NAMS is a great resource. Their website is menopause.org. Great resources if you treat a lot of menopausal women. They also said a few things that women who want to use local hormone therapy and they have triple negative breast cancer, that's reasonable to do that, but the data are lacking. So just to kind of sum it all up, I have no idea if that was about 45 minutes, but I think so. Since the WHI, an entire generation of women might have missed out on the benefits of hormone therapy. And we as practitioners can really change the dialogue surrounding hormones, especially after this week and the risk of breast cancer. And then don't forget about the important effects of hormones, of estrogen specifically, and testosterone actually, on the genitourinary tract. And using it vaginally is, really low risk and can really make a huge difference in a woman's sex life and for her partner, in her overall happiness, well-being. So don't forget about that aspect. Even though it might be a little embarrassing to bring up and talk about, you can really help a lot of women. So I just want to end it here. I love social media. I love posting interesting articles on menopause and sexual health all over social media. So please, please, please follow me on Instagram and Twitter and Facebook. I also have a YouTube channel, and I created this I created patient education videos because I found myself talking a lot about the same things over and over again. And many women would say, oh, I'm not going to remember this, or I wish my partner were here to hear you speak about this because he needs to know it too, and he's not here, or she, or whomever, or they. All the YouTube videos, obviously everything's free, but they're just good patient education resources if you're interested in learning or if your patients are. My practice is in St. Louis, a little outside St. Louis in Chesterfield. I do in-office visits, but I also do telehealth. So as long as they're in Missouri, I can see patients via telehealth, and it's proved to be one of the greatest things. And I actually was doing it before the pandemic. But if any of your patients have sexual or menopausal problems that are just, something that you either don't have time to handle or don't want to handle, please feel free to refer them to me. You can also shoot me an email through my website if you just have a question. I don't mind curbside consults. I like talking about this stuff. So anyway, thanks for listening. I hope this recorded. And I will be here to answer your questions.